Okay, well, we are going to go ahead and get started. Hi, everyone. I'm Maggie Nelson. I'm a third year Peds resident presenting NICU Journal Club today. For anyone trying to find JD and I in person, we are on the first floor west conference room A, but you're welcome to join us online as well. So the paper that we are going to be examining today is called Lung Ultrasound Score Progress in Neonatal Respiratory Distress Syndrome. And the objectives of this talk are pretty straightforward. We're going to look at the article, understand its uses and limitations, talk a little bit about the clinical concepts of lung ultrasound and respiratory distress syndrome, and then discuss multiple parts of the article, but statistics, internal validity, and external validity to be specific. Okay, so there's a certain way that I like to go through papers guided by our own journal club curriculum. So let's just start walking through methodically what this paper is looking at. So starting with the clinical question, the overall clinical question, as I understand for this paper, would be, can lung ultrasound be used as a reliable respiratory marker throughout a neonate's hospital stay? And the type of study that this is just a prospective, multi-center, and observational study. So it's not a randomized controlled trial. It's more looking at the length of neonates hospital stay and correlating that with some clinical factors, as well as the lung ultrasound performed by the investigators. So the way that we like to work through papers here is to start by asking a series of questions. So the first question is who, and that concerns who wrote this paper. You always want to put that into context. So the main author on this paper is a guy from Italy called Francesco Raimondi. He is an MD, PhD, and he is the chief of the Division of Neonatology at the University of Naples in Italy. He did his training stateside at the University of Maryland, where he did a pediatrics residency and neonatology fellowship. He is quite widely published. He has 208 articles that I was able to find just through OneSource ResearchGate. Over 10 articles I was able to find in the last 2 years, specifically regarding neonatal ultrasound. There were other articles that were not regarding neonatal ultrasound. He's talked about different things such as lung ultrasound predicting extubation failure, predicting admission to the NICU, guiding surfactant administration, and diagnosing pneumothorax, of multiple other things. So clearly lung ultrasound is something that Dr. Raimondi is passionate about and has been published for multiple times. Okay, so why was this study done, aka what is already known on this subject of lung ultrasound in neonates? So lung ultrasound is a bedside non-invasive technique that has been shown to be useful in the differential diagnosis of neonatal lung disease, predicting need for non-invasive ventilation versus invasive respiratory support. And then lung ultrasound scoring specifically, which we'll talk about shortly, has been established through multiple research papers and has been used to make clinical decisions such as surfactant administration in the NICU. Most of this work is from a single center. Most is European, actually, from France and Italy. And it's also a lot of the lung ultrasound work is performed early in the disease process or early in the NICU stay for these neonates. So the next why question is looking at what this paper hopes to accomplish. So this paper aims to investigate the lung ultrasound findings during the entire NICU admission of preterm infants with respiratory distress syndrome, and lung ultrasound for this paper was correlated with gestational age, a ratio of SaO2, so the oxygen reading that you get in the pulse ox for the patient, to FiO2, or the fraction of inspired oxygen provided by CPAP or what have you, and postnatal complications. So where was this study done? This was a multi-center study that was carried out in 8 level 3 Italian NICUs. So these are multiple cities that the NICUs were in. This beautiful picture is of Ancona, Italy. I'm sure I'm pronouncing that incorrectly, but I never heard of it, so I had to look it up. And just a little bit of investigation on how this compares to our population. What I was able to find is that while Italy does have a variety of SES classes, similar to the US, the population is quite less diverse than here. They are approximately 92% Caucasian/white. Okay, so when was this study performed? The study was completed between May 2018 and May 2020. It was published in April 2021. And 240 infants total were enrolled during that time. They did not tell me this, but basic math on my part would show that about 15 infants per institution per year would give you 240 over that study time span. The next question is what journal? So this study was published in Pediatrics in April 2021. Pediatrics is a journal that a lot of us know and love as pediatricians. It's highly regarded, it's high impact within the field of pediatrics. And I found from their website, they say they're one of the 100 most cited journals in science and medicine overall. I know that I usually take papers that come from pediatrics a little more seriously than other papers. Their impact factor is around a 5. Okay, so getting into our next question of how. So how was the study completed or study design? The inclusion criteria for this study was premature infants with clinically diagnosed respiratory distress syndrome. So you can see pulled from Up to Date, an example of the chest x-rays of neonates with respiratory distress syndrome here on your right. And you can see that the characteristic chest x-ray is going to be low lung volumes with decreased aeration and diffuse reticulogranular ground glass appearance in air bronchograms. You're also going to see respiratory distress, so retractions, tachypnea, potential FiO2 requirement or pressure requirement in the first few hours after birth. This is usually clinically diagnosed based on the presentation of the neonate and the chest x-ray that is characteristic. And in this study, they said that neonates had to have retractions and had to have a characteristic x-ray in order to be diagnosed with RDS. The gestational age examined for the study was 25 and 0 to 33 and 6. And they were divided into 3 different groups based on gestational age: 25 and 0 to 27 and 6, 28 and 0 to 30 and 6, and 31 and 0 to 33 and 6. These babies were enrolled within 72 hours of their birth and or before the first surfactant administration. So who did they exclude from the study? Gestational age that was outside of criteria, postnatal age beyond 72 hours prior to enrollment, and then major congenital malformations that they felt would confound the findings of the study. Next, for study design, we can talk about consent and approval. The parental consent was obtained for all infants, of course, and the study was approved on multiple levels. So there was the University of Naples Ethical Committee that approved the study, and then ethics committees at each participating hospital provided their approval as well prior to moving forward. And this is just a picture of Naples. All right. So next is the lung ultrasound process. So a complete lung ultrasound for these infants was performed within the first 24 hours of life, or T0, and then weekly afterwards. So T1 after the first week, T2 after the second week, and so forth. The ultrasound was performed by an experienced ultrasound technician using linear or microlinear high frequency transducers. The gain on that ultrasound was just determined by the software locally, and then the focus for each ultrasound was placed on the pleural line, and the depth was made just below that pleural line. Clips for the ultrasound was taken in 3 specific places and then bilaterally, so 6 clips total. I don't know if this is a European thing, but I had never learned so much about the Emma Clavier line, so that's why I've placed this graphic here. You can see Emma Clavier is at the basically nipple line here, and then we are more familiar with the anterior axillary and posterior axillary lines. So the anterior axillary is going to be your line 5 here, and then posterior axillary would be behind the axillae. Can't quite see it on this graphic, but we're more comfortable with those areas. So you're going to see 4, 5, and then posterior axillary, and those clips would be taken on both sides, so 6 clips total. So how did they score the lung ultrasounds? Now, I'm not an ultrasound expert, but there's a very helpful graphic in the supplementary information of this paper to help me understand. So a score 0 is going to be your best score, and then it gets worse as you work your way up. So score 0 is demonstrated here on the top left. That's a clearly hyperechoic image of a pleural line with lung underneath, so you can see that you have a well aerated lung as demonstrated by this nice black area underneath your pleural line. A score of 1 is demonstrated here in B, and that is a it shows hyperechoic striae replacing horizontal reverberation. So that is a fancy way to say you're seeing more white here with streaking, and that shows decreased aeration. And thanks, Dr. Vinslov. Yeah, I think it might just mean midclavicular, just European terms. All right, so score of 2 is pretty easy to differentiate from the others. That's going to be a basically white lung. We're all comfortable with seeing a white lung in RDS on chest x-ray, and this is the same thing demonstrated with ultrasound. Obviously, this is going to denote decreased aeration. And then a score of 3 is our worst score, and it shows a markedly irregular pleural surface over a white lung. So you already have a white lung, and now it's getting really irregular. So you're seeing, instead of nice, beautiful lines, a lot of irregularity within a decreased aerated lung. So the total score for a patient would be from 0 to 18, because remember, you're going to have 6 areas total per patient, and you can have a max score of 3 for each image. So it'll be 0 to 18, simple math. Okay. So how was this scoring assigned? The scoring was assigned by, they said, a local ultrasonographer. So I assume that would be the same as an ultrasound tech here. They didn't mention anything specifically about a radiologist. And then there was inter-observer agreement performed with another local ultrasonographer, and then not half of a principal investigator, but 1 out of 2 of the PIs would also look at these images and assign a score. And then we'll get to this in the stats part, but basically they looked at inter-rater variability to make sure that the scoring was consistent. So clinical care, such as giving surfactant, was given based on their European guidelines, which are very similar to ours. If a baby requires intubation, they get surfactant. If they have a persistent increased FiO2 requirement or respiratory acidosis, they would get surfactant within those first 24 hours of life, and repeat surfactant administration would be based similarly. So those clinical decisions were made based on their clinical guidelines, not based on lung ultrasound, and they were actually done by a local attending who did not have any knowledge of the ultrasound scoring. Okay, so how was the data collected? Prior to each ultrasound, a local physician would record blood gas results, respiratory support mode, clinical complications that occurred in the time since the last scan, and then that SaO2 or F to FiO2 ratio. And the SaO2 was maintained in the 90 to 95% range with appropriate FiO2, and specifically the SaO2 was measured in the right hand of the infant preductally. All right, so let's talk a little bit about the outcomes they were looking at for this paper. The primary outcome is just basically to look at the lung ultrasound trajectory over the course of the NICU admission. And they wanted to look at a correlation between the lung ultrasound score and the SaO2 to FiO2 ratio to see if there was any significance. Some secondary outcomes, they wanted to look at the lung ultrasound score and FiO2 ratio within those 3 gestational age subgroups. So to see if there was any change based on what gestational age you were at birth. And then to look at the lung ultrasound time course as it compares to different complications. So the clinical complications they looked at were sepsis, PDA requiring treatment, pneumothorax, and pulmonary hypertension. All those were very clearly defined, and you can see that easily within the paper. And then specifically, they wanted to look at the lung ultrasound course in patients who ultimately developed bronchopulmonary dysplasia defined as patients who are on some sort of respiratory support at 36 weeks, corrected gestational age, and severity of BPD is defined by the paper based on the type of respiratory support that they're on. And that's all in the supplementary information. All right, so as far as data analysis now, I'm not a stats person, so I'll get through this as best as I can. But basically for the lung ultrasound scoring, they looked at a Cohen's kappa coefficient to assess inter-observer variability. I'll talk about that a little more shortly because I didn't know as much about this Cohen's kappa. And then we're more comfortable with students' t-test and Mann-Whitney U-test. So those were performed to compare infants with complications to those in the control group. So a t-test, as most of us know, is one of the most used statistical procedures. It tests the hypothesis that the means of two groups are the same, and then either proves or disproves that hypothesis. The t-test assumes that the variable in question is normally distributed in the two groups. So when you don't feel you have normal distribution, that's when you use a Mann-Whitney test. Then they looked at the relationship of the lung ultrasound score and that SF ratio over time using mixed effect models, and gestational age is a main fixed effect over time. And then finally, to look specifically at the prognostic value of lung ultrasound for BPD. So based on what your lung ultrasound is, even at day 7 of life, whether the patients will ultimately develop bronchopulmonary dysplasia. They use a logistic regression analysis for this and looked at medical complications, gestational age, and birth weight as covariates. Hi, guys. Okay. So to talk a little bit about the statistics here, usually on journal clubs, we're asked to focus on one specific statistical learning point and explain that to everybody. So what I decided to look at was Cohen's kappa coefficient because I didn't know so much about it. So Cohen's kappa is a statistic used to measure inter-rater reliability for qualitative items. So for here, the qualitative item is the lung ultrasound score, 0 through 3. It's thought to be more robust than just percent agreement. So like the raters are in 90% agreement, as it takes into account the possibility of agreement by chance. So you can see the equation used to estimate kappa on the top right. The P0 here is going to be the relative observed agreement between the raters. And then your PE is the hypothetical probability of chance agreement. So kappa of 1 happens when raters are in complete agreement, and kappa of 0 is when there's no agreement other than what would be expected by chance. So a negative kappa is actually possible, but it occurs when agreement is worse than what would be expected by chance. Okay, so moving into the results here, this is just a data telling us a little bit about the clinical population that they were able to capture. So our overall N was 230, and you can see based on the gestational ages, there were 65 in the 25 to 27 week group, 76 in the 28 to 30 group, and 99 babies in the 31 to 33 gestational age group. And this tells you a little bit about their birth weight. Understandably, birth weight's going to increase with gestational age, whether there were a spontaneous vaginal delivery, whether there were maternal complications, your APGAR scores, steroid use, surfactant use is going to be higher, of course, in your younger babies, and then get a little bit less common in your older babies. PPV use, you see the same trend, and then major complications. So the trend you can see with the complications, especially, is that you're going to see more complications in your younger infants or lower gestational age. And that also, I would say, is to be expected. So nothing here is too surprising. We, of course, have more babies in our 31 to 33 week group because it's just more common. So that doesn't surprise me either. Overall, with these babies, they followed them throughout their NICU stay and did a total of 1,871 complete scans as they did these weekly in the babies. All right. So moving on to our figures, starting with figure 1 in this paper, we're looking at lung ultrasound scores. Of note, the lung ultrasound score kappa coefficient was calculated as 0.91, and as you guys remember, a score of 1 would show complete, perfect agreement. So that's pretty good. This figure shows us the time course of lung ultrasound score and that SF ratio as separated out by 3 gestational age patient subgroups. So you see the darkest box is the youngest babies, and then you get lighter as you go towards those older gestational age groups. And as you move across this axis, we see the weeks, and you see the SF ratio in as you go up and down on our chart B, and you see our lung ultrasound score on chart A. So we're just looking at lung ultrasound score over time and SF ratio over time for these babies. This figure demonstrates that there was a significant negative trend in lung ultrasound score, an upward trend in SF ratio for the whole study population overall. And they found that there was a significant difference between the lung ultrasound patterns for the least mature infants and each of the other 2 age groups, with a widening difference over time. They also found a significant difference between the 2 older age groups that changed over time. So overall, what this is showing is something that doesn't really surprise me, that lung ultrasound score, if you remember, a worse lung ultrasound score shows worse aeration of the lungs. That score is going to improve as babies get older and their stay in the NICU progresses. And you're going to see overall that babies that had a higher gestational age on admission will have a better ultrasound score when they first present, and that will improve over time, just like our younger babies. Similarly, the SF ratio will improve over time because a higher number for the SF ratio is a better number for all age groups. The SF ratio shows a positive pattern that's significantly different among age groups, and you see a time-dependent difference only between the least and most mature age groups here. Okay, so the next figure is looking at lung ultrasound score and SF ratio relation according to time and gestational age. So this was a little confusing when I first looked at it, so we can walk through this together. Each figure is going to be for a different gestational age group. So you have 25 to 27, 28 to 30, and 31 to 33. Then as far as the axis, that's going to show better oxygenation. And on the y-axis, you're going to see your lung ultrasound score. Now, as your lung ultrasound score goes up, it correlates with basically decreased aeration. A bigger score is worse for the baby. So it would make sense that you have a negative trend or an inverse relationship where you have a better SF ratio when you have a better lung ultrasound or a lower score of lung ultrasound. Now, when you have a lower SF ratio, you have a higher lung ultrasound score. And that figure showed exactly that. A significant inverse relationship between the lung ultrasound score and the SF ratio over time was shown for all gestational age groups. But you can see that over time, as you look at different gestational age groups, it looks like this curve is getting a little bit sharper. And it indeed did show that the interaction between gestational age and the SF ratio was statistically significant, suggesting that the strength of the inverse relationship increases with gestational age. So I found this interesting. Obviously, you can see that the data is not the tightest. You have outliers in every group, but you can see a statistically significant inverse relationship between that SF ratio and lung ultrasound. And it does seem to get stronger as the gestational age increases at birth. Okay, so next the paper wanted to look at infants with specific complications. We addressed this a little bit earlier. And the complications that they looked at included sepsis, PDA, pneumothorax, pulmonary hypertension, and bronchopulmonary dysplasia. There were 8 NICUs that were examined, but all the NICUs used the same clinical criteria for diagnosis of these complications. The vast majority of patients in the 31 to 33 groups did not have any complications. So you can note that this table is only looking at patients that were in the 25 to 30 week gestation groups because they just didn't feel it was worth it to look at that older group. So this separates babies out by babies that experience complications and babies that experience no complications. When you look at just 25 to 30, they were able to get pretty equal ends. 72 had some sort of complication and 69 babies had no complications. Then you're going to be looking at basically the same stuff we saw on the previous table, looking at babies, but specifically it goes into the major complications. So you can see that sepsis was the most common complication seen. Then PDA, specifically this is PDA requiring either medical or surgical treatment, because we know a lot of our babies have some sort of PDA that we never do anything with or never have to do anything with. Then pneumothorax and pulmonary hypertension. Your third most common complication seen was bronchopulmonary dysplasia, described as a need for oxygen support at 36 weeks post-menstrual age. Okay, so next, they wanted to look at these babies 25 to 30 weeks. So they're combining two different gestational age groups now, and they're putting them in groups based on their complications. So your darkest box is going to be your uncomplicated babies. Your next box is complicated with bronchopulmonary dysplasia, and then complicated with no bronchopulmonary dysplasia. So those that were complicated with bronchopulmonary dysplasia had an N of 17, and those that were complicated but no bronchopulmonary dysplasia had an N of 51. So this figure is looking at over time how the lung ultrasound score changed for these three different groups. So those that were complicated, uncomplicated, and bronchopulmonary dysplasia with complications. And infants with complications, including bronchopulmonary dysplasia, had a significantly higher lung ultrasound score than infants with complications but no bronchopulmonary dysplasia. And both groups had higher lung ultrasound scores throughout their course as compared to neonates without complications overall. So that would make sense. Those, especially those with bronchopulmonary dysplasia, having a higher lung ultrasound score throughout their course, to me makes a lot of sense. And then I find it kind of interesting that they found that those that had complications such as sepsis and pulmonary hypertension, pneumothorax, et cetera, but were never diagnosed with bronchopulmonary dysplasia, also were found to have a significantly higher lung ultrasound score throughout their course as compared to those that were uncomplicated. Okay. So next we're going to talk about what they did with logistic regression models. So a logistic regression model was built to assess whether that lung ultrasound score was an independent predictor of ultimate development of bronchopulmonary dysplasia in these babies. Gestational age, birth weight, and complications were kept as confounding factors, and they also looked at the odds ratios for those as well. Odds ratio, just to remind all of us that, like me, aren't the biggest stats whizzes, was calculated for those with and without complications based on their lung ultrasound, specifically at day 7 of life. So that's your T1 lung ultrasound. And to remind everybody, an odds ratio is basically looking at your odds that a case was exposed to something over your odds that a control was exposed to something. And you're looking at whether someone had a disease or did not have a disease. So you're looking at basically how much a certain exposure is going to make you, whether it's going to make you more likely to ultimately develop a disease. An odds ratio of 1 would mean that there's basically no effect of that exposure on developing the disease. An odds ratio less than 1 would mean that there's actually a protective effect of that exposure on developing the disease, and an odds ratio of greater than 1 would show that that exposure is going to make somebody more likely to ultimately develop that disease. So the lung ultrasound score at day of life 7 was ultimately found to be an independent predictor of bronchopulmonary development at 36 weeks corrected gestational age, with an odds ratio of 1.19. So remember, greater than 1 means that you would be more likely to develop that ultimate disease. They also calculated odds ratio for these other factors. So overall, just having complications throughout your stay, kind of interestingly, was found to have a stronger odds ratio on ultimately developing bronchopulmonary dysplasia with a ratio of 1.34. And then these to me make sense. So your odds ratio for gestational age, as your gestational age increases, you're going to be less likely to ultimately develop bronchopulmonary dysplasia. And then your odds ratio for birth weight was actually 0.31, which is our most significant, showing that as birth weight increases, the ultimate risk of developing bronchopulmonary dysplasia also decreases, and that makes sense to me as well. So using the logistic regression model, a receiver operating curve was created based on that model to determine how effective lung ultrasound score is at predicting bronchopulmonary dysplasia. So We know that there is some sort of correlation, but how effective is that score? These receiver operating curves basically plot a true positive rate against a false positive rate, and then look at your area under the curve, or AUC. The overall AUC for this effect of lung ultrasound score on development of BPD was found to be 0.89. 0.1 is going to be your highest effect. And specifically for the 28 to 30 week group, the area under the curve was 0.89. Overall was 0.82. Okay. So next is figure 4, and this looks at that prediction of bronchopulmonary dysplasia. So higher risk of bronchopulmonary dysplasia as determined by their logistic regression model. You're going to have a higher risk of BPD as this number goes up, higher risk of BPD as this number goes up. And both of these graphs look at lung ultrasound score, so increasing lung ultrasound score as you go across your x-axis. And then the difference between these two graphs are that this graph is separating out complicated versus uncomplicated infants. And this graph, graph B, is looking at infants based on gestational age. So you can see with both of these graphs, as your lung ultrasound score at just day 7 of life goes up, that your chance of bronchopulmonary dysplasia is also going to increase. You can see a little bit of a stronger association for patients that were diagnosed with complications, and you can see a significantly stronger association for patients in the 28 to 30 week gestation group as compared to the 25 to 27 gestational age group. I found this very interesting. I mean, a higher lung ultrasound score for a 28 weeker, if you believe these stats, is going to be a lot more helpful in knowing whether that patient is going to ultimately develop BPD as compared to a 26 weeker with a lung ultrasound score of 15. So this I found very interesting differentiation. Okay. So now I'll move into the discussion part. And anybody, we'll have like time to talk about this, but anyone feel free to chat in your thoughts on these figures and these stats. So a way I've always been taught to look at and examine a paper is thinking about internal validity and external validity. So internal validity, does the study address a clearly focused issue? I would say, I think yes. I mean, it looks at neonates and their lung ultrasound score, specifically in neonates with RDS throughout the hospital stay, and it knows what it's looking at, knows what it's has defined complications, defined bronchopulmonary dysplasia. Was the cohort recruited acceptably? It seems so. There was written parental consent. It was approved by multiple committees. It was a multi-center study. And was the outcome accurately measured? So the outcome was mostly this lung ultrasound score, and it was read by what they said was a local ultrasonographer. So to me, I think that would mean technicians. I don't think that's necessarily radiologists. It was checked with good inter-rater reliability by one of their 2 PIs who were neonatologists. The only thing I'd note here is it doesn't seem like a radiologist was involved in the study. Now, I'm sure that it seems like reading the lung ultrasound was pretty straightforward and that there was good inter-rater reliability, but just something to note. Additionally, have authors correctly identified confounding factors? I mean, I think they have to some extent. They looked at complications, they looked at gestational, let's just say gestational age, but there were some things that they probably didn't focus on. Maternal variables, I saw on the graph or the tables they gave us, they looked at some antenatal complications, but it didn't look like that was carried out in a lot of the different studies. Whether the patients were small for gestational age or LGA. And then they also talked about surfactant administrations being guided by clinical factors, which I think was the correct clinical decision, but they didn't talk about the clinical factors in decision-making for a second or a third dose of surfactant. And as we know, that can also have an effect on a patient's ultimate course. So just another thing that they could have accounted for. And then was follow-up of subjects complete enough? I think so. They were followed through NICU stay, whether that ended in discharge or mortality. So I think it'd be hard to follow them further than that. Next, we usually look at external validity. So can the results of this study be applied to our local population? Overall, the population in Italy is demographically less diverse than the US population, although they did look at 8 different cities that seem to have a variety of socioeconomic statuses, something to keep in mind. And then do the results of this study fit with other available evidence? I would say overall, yes. So this paper did cite several other papers that were not only performed by this paper's PI that showed that overall lung ultrasound scores do correlate with clinical outcomes. And it kind of argues that it was the first one that showed correlation with clinical outcomes throughout NICU stay. So what do we think this study overall adds? So it is the first large multi-center study examining the use of lung ultrasound on neonates throughout the entire duration of their hospital stay. It is stratified by gestational age and other various factors that we've discussed. And then the paper argues that it demonstrates that lung ultrasound has a significant correlation with gestational age, so a worse score in more premature infants, and also on the presence of complications and that SF ratio, as we saw in our figures. They also argue that the lung ultrasound score is an early predictor of eventual bronchopulmonary dysplasia development, as we saw that day of life 7 lung ultrasound score did seem to correlate with the eventual prediction of developing bronchopulmonary dysplasia. The authors also argue that lung ultrasound can identify high-risk infants early on and may reduce the need for excessive radiation or blood draws to track respiratory status. So if you've got this intervention that doesn't require radiation, doesn't require sticking the baby, you can do it kind of throughout their stay to track how they're doing. Could you potentially cut down on the number of chest x-rays that you're doing or the number of blood gases that you're doing? They also argue that they've established lung ultrasound as a predictor for the eventual development of bronchopulmonary dysplasia, and this predictor really does seem to increase in strength with the gestational age of the infant. So what are the limitations? So this is kind of a combination between what the paper noted as its own limitations and some things that I noticed. So the SF ratio was used in an effort to be less invasive, and in contrast to a PaO2 FiO2 ratio, which may be a little more accurate, although they did cite multiple papers that showed that the SF ratio could be something good to use in place of that PaO2 FiO2 ratio. Other papers have predicted BPD from lung ultrasound with some better positive and negative predictive power, and this paper did note that, but said that those papers looked at different points in time and looked at a lung ultrasound closer to the time of development of BPD as compared to this paper. And then just kind of a note about the size of the study. It wasn't a tiny study, but the overall N was 240 infants with RDS, and there were some size differences between the gestational age groups. So the lowest gestational age was 65 and the highest was 99. And ultimately that 99 age group, 31 to 33, a vast majority didn't develop BPD, so they didn't end up looking at them. So I think a larger study would be more helpful to look at significant differences between groups. And then, of course, this was just an observational study. So it wasn't a randomized controlled trial. It wasn't looking at a direct effect of using lung ultrasound scoring to impact decision making. So just have to take observational studies a little bit lighter than other types. So then at the end of looking at papers, you always want to talk about whether this would actually change your clinical practice or make you think about lung ultrasound scores or infants with RDS and BPD differently. And that's when I usually like to kind of open things up. We've got the majority of people on chat, so if anybody has anything to add, feel free. So I've got Dr. Patel saying, was there any commentary about interventions after 7 days of life that could impact patients developing chronic lung disease, such as use of steroids? So Dr. Patel, I think that's a good comment and a good note on the limitations of this study. They basically said that things like steroid administration, similar to administration of surfactant, was just guided by the local attending's clinical decision making, and they didn't note that they stratified patients or accounted for administration of steroids or other support throughout the stay when looking at that eventual development of BPD in their ultimate statistics. And then he also said, with any commentary about why the lung ultrasound increased at weeks 5 and 6 for the 31 to 33 weekers. Here, let's see if we can find what you're talking about here. 25 to 30. Oh, okay, I see what you mean. So what they did say, and what Dr. Patel is talking about here, is that you kind of see this overall decrease in lung ultrasound score, and then it kind of pops up at week 6. So the thing to keep in mind about this study is that it only looks at these infants throughout their stay in the NICU. And so the N for each week is going to progressively decrease, especially when you get up to these weeks 4 through 6 for your patients born at 31 to 33, because your uncomplicated patients born 31 to 33 are probably going to be discharged by that time, and you're going to be left with the patients who were there because they had more severe complications or struggled more on CPAP longer, etc. So there was some commentary about this group having a little bit of a rebound effect at the end, and that was attributed to the fact that the N was progressively decreasing and you were seeing patients that were still there because they were sicker, on admission, if that makes sense. Right. So we just had a really helpful comment from the room, and I don't disagree with you. So the kind of comment / clinical question is, so now we know that lung ultrasound scores may eventually correlate with development of bronchopulmonary dysplasia. Kind of, so what? How is this going to change the treatment of the baby? And does it really help us in our clinical treatment? And I think that's a good question. This is just an observational study. It's not looking at, a treatment and an effect. I thought it was interesting because it was recent. It was in pediatrics. It seems to be kind of a hotly discussed topic right now, especially a lot of these studies are coming out of Europe. But that was a question of mine too. I can do a lung ultrasound every week for my patients, maybe, and correlate it with my blood gas or whatever, but is that going to affect how I treat my patient in the long term? And I'm not a neonatologist, but I don't think it would necessarily affect my clinical decision making day to day. Now, I think they're arguing that, well, if you just do your day of life 7 lung ultrasound, you can kind of stratify your patients and understand whether they're going to be at risk later on. That could be helpful, especially just from a clinic, or maybe just interesting from a clinical standpoint, that this patient's maybe higher risk, but are you going to treat that patient differently from other patients? Why would you give them an intervention and someone else not an intervention just because you feel their lung ultrasound scores worse? I don't think we're at that point that they can make those recommendations. So it's almost more just a study about eventual risk, like high risk, low risk categories for infant, but they don't really talk about what you would do with that score. But that would be something that'd be interesting for further research for sure. Yeah, I agree. So Dr. Seawatch has an interesting comment. So he's saying, well, the authors of the paper are arguing that this may be a good substitute for serial x-rays. And I don't know, maybe it's more common in Europe or other NICUs to do serial x-rays that would expose baby to excessive radiation. But he's stating that here that we don't really do serial x-rays in babies unless there's a clinical indication that blood gases are looking bad, etc. So in this NICU, he feels like doing regular lung ultrasounds would likely not take the place of a chest x-ray. And if a patient was looking bad enough that they needed an x-ray, you probably would do an x-ray anyways, rather than relying on a lung ultrasound. So I agree. I think that while this is interesting, and while it's always interesting to learn about other new non-invasive types of imaging, I'm not sure that the lung ultrasound would replace x-rays, because if we need an x-ray, we need an x-ray. If someone got really comfortable with lung ultrasound and trusted them, could it potentially replace blood gases? Maybe. But I think that blood gases are so ingrained in the culture of the NICU that it would be really hard to get to a point where you're relying on your ultrasound and not your gas. You like it? Yeah. Right. Yeah, so we're saying in the room that that's an interesting thought, and it would be nice to get to a point where we don't have to stick babies all the time for blood gases, and if we trusted lung ultrasound enough to help us replace some blood gases, that would be an interesting thought. Let's see, we've got a couple other things. Yeah, so Dr. Patel says it might be helpful. It would guide us to treat PDAs more aggressively in the 7 days if the lung ultrasound is higher. So that's a good thought, that maybe if a patient had a PDA and now their lung ultrasound score is not great at 7 days of life, that maybe you'd be a little more aggressive with that PDA because they're also at risk for chronic lung disease. So that's very interesting. And then Dr. Bins-Loveman, though non-invasive ultrasound is not benign, the ultrasound waves can cause cellular damage. There's actually an exposure score that increases frequency and time and should not be exceeded. The lung is the most sensitive organ to ultrasound damage. The effect on preemie lungs over time has not been studied and defined. So that's a very interesting point that I think we should all keep in mind. And then Dr. Bins-Loveman says, it looks like the predictive value might be better at 3 to 4 weeks when we consider systemic steroids. Did they comment on predictive value at other time points? I didn't see that. They mostly focused on that day of life 7 because I think they were really trying to look at development of complications over time, Dr. Bins-Loveman. That might be something that they talk about in the supplementary data, but this paper specifically is focusing on the predictive value of that lung ultrasound score on that early image, that week 1 image. Then we've got, I think that's Dr. Warwick, some units will still use serial x-rays even up to daily if intubated, especially on high frequency. Wow. So in a unit that's using serial x-rays that are daily, maybe a lung ultrasound would be a good solution to decrease on that radiation. And then Dr. Bins-Loveman says bedside ultrasound in the NICU is more common in Europe, so that a radiologist not being involved makes sense. So that's helpful to know. It definitely seems like a lot of this ultrasound data is coming out of European NICUs, although I did see some American studies. So it makes sense that that's more widespread there. Okay. So overall, I just thought this was an interesting study. And ultrasound definitely seems to be in the zeitgeist. I saw a lot of different studies on lung ultrasound. So just something interesting to chat about. Does anybody have any other thoughts or comments? I can scroll to my references here. I had to put a baby with pasta because it's on Italian babies. So, all right. So if nobody else has anything, I can let